Hello friends, welcome to Prep Ladder ETSS. This is Dr. Santosh Patil, your mentor for medicine, and in this video module we will be learning about IgG4 related diseases. Now these are a group of disorders which have garnered a lot of attention in the recent times because we understood the basic pathophysiology behind this set of disorders. Now majority of these disorders in the past were recognized as individual entities, but because there were common threads binding these disorders, now they come under a broad umbrella called as IgG4 related diseases. Okay, now what is the basic introduction that I can give about the disease? It is a group of disorders affecting multiple organs characterized by fibrosing inflammation of the affected organs, and this inflammation is characterized by infiltration of the affected organs by cells which test positive for IgG4. Okay, this is a basic understanding. Okay, but these disorders share a lot more characteristics. That is why they are all coming under this broad heading. Okay, so what are those characteristics? The characteristics of IgG4 related disorders are the common characteristics that come under this, right? Number one, the multi-organ involvement. Though we know that, see, some of these entities we recognize as a one particular organ involvement, but those patients, when tested for other organ involvement, often test positive, right? Clear? Multi-organ involvement, number 1 point. Okay. Number 2, in the affected organ, you will see either fibrosing inflammation or tumefactive lesions, which are due to both the fibrosing inflammation as well as tumefactive lesions are due to infiltration of the affected organs by IgG4 positive lymphocytes or plasma cells. Okay, and if you biopsy these patients' affected organs, right, what are you going to see is the fibrosis that is seen here is often described as storiform fibrosis. Okay, now you might ask me what is storiform fibrosis. I'm not a pathologist to give you a very proper understanding of what it is, but my rough understanding is storiform means cartwheel-like. So the fibrotic bands are arranged like a cartwheel, right? So simplest way to remember is cartwheel-like arrangement of fibrosis. That is what we call as storiform fibrosis. And the last point to remember is the presence of obliterative phlebitis. So in the affected organs, right, the venules are developing obliterative phlebitis. Okay, so these are the common shared features. And when I'm saying that the IgG4 positive cells are infiltrating the organs, you might even expect these patients to have elevated serum IgG4 levels. So that is one more point that we need to be aware of. Elevated serum IgG4 levels. Okay, so I'm again reiterating what are the common features that are shared by all the disorders that come under the IgG4 related diseases. Number one, as such, multi-organ involvement. Though the presentation may be with one organ involvement, the other organ involvement is extremely common. Okay. Number two, presence of fibrosing inflammation and tumefactive lesions in the affected organs. Now some of you may be asking me, what is tumefactive lesion, right? Tumefactive basically means tumor-like. So patients have tumor-like lesions in the affected organs. That is why we call them as tumefactive lesions. Why tumor-like? Because very large number of plasma cells are infiltrating the affected organ, and that infiltrated area might start looking like the tumor. So it might clinically or radiologically confuse like tumor. In fact, I can state an example of one of the patients we had seen where initially the patient was suspected to have a CA head of the pancreas, though it was the IgG4 related autoimmune pancreatitis, or what you call as type 1 pancreatitis, autoimmune pancreatitis. The patient was initially diagnosed as having the carcinoma of the head of the pancreas, because head of the pancreas is the most common site for the CA pancreas, and that also will present as an obstructive jaundice. So this patient also presented with obstructive jaundice. It was painless, and the imaging showed that the head of the pancreas was enlarged in size. So that made the radiologist think that it could be a CA pancreas. But because the treating team was also aware about the autoimmune pancreatitis, and the markers were not consistent with the diagnosis, and the subsequent imaging was also not consistent with the diagnosis of CA pancreas, we went ahead with the diagnosis of the IgG4 related or type 1 autoimmune pancreatitis. A trial of steroids caused the regression of the bulky head of the pancreas, confirming that we were right on track, right? Okay, so that is one more important point to remember. Tumefactive lesions. In fact, there's a sub-entity of IgG4 related diseases called as IgG4 related hypophysitis, where the stalk of the pituitary gland can develop infiltration of the IgG4 positive cells and even the posterior pituitary, and that can mimic like the pituitary tumor. So many times the radiologist might report it as a pituitary adenoma or a suprasellar mass, sometimes believed to be compressing the stalk of the pituitary gland, but it may be because of the infiltration of the organ by the IgG4 positive cells. Okay, now these are the common characteristics. Okay, now then comes the question, what are the diseases which we recognize as individual entities in the past now are considered as the IgG4 related diseases? So let me take you through a table which kind of mentions all the important diseases that you need to know. So guys, now when you look at this table, right, many of these disorders are already recognizable to us, right? From our MBBS days, we are very much familiar with the parotid gland involvement, that is your Mikulicz disease. Then we are also aware of the Kuttner's tumor, Riedel's thyroiditis. Then Ormond's disease was very familiar term for all of us, right? So these are all now considered as IgG4 related disease. I would expect you to remember the entire list, because you can see a kind of MCQ asking you which of the following is considered as an IgG4 related disease. So we need to remember all the things that are mentioned in this table, starting from Mikulicz disease, Kuttner's tumor, Riedel's thyroiditis, eosinophilic angiocentric fibrosis, multifocal fibrosclerosis, lymphoplasmacytic sclerosing pancreatitis or autoimmune pancreatitis. Remember, the autoimmune pancreatitis is of two types. The autoimmune pancreatitis that is IgG4 related is autoimmune pancreatitis type 1. The type 2 autoimmune pancreatitis is called as idiopathic duct-centric pancreatitis, IDCCP, right? Okay, now inflammatory pseudotumor, fibrosing mediastinitis, very common, sclerosing mesenteritis, even periaortitis or periarteritis can happen, retroperitoneal fibrosis or Ormond's disease. We used to be asked about this in the surgical vivas. Inflammatory aortic aneurysm, cutaneous pseudolymphoma, idiopathic hypertrophic pachymeningitis, idiopathic tubulointerstitial nephritis, and also idiopathic hypocomplementemic tubulointerstitial nephritis with extensive tubulointerstitial deposits, membranous glomerulonephritis, and idiopathic cervical paravertebral fibrosis. So these are all the disorders you need to remember. Now, apart from this, examiner might also ask you what is the most commonly affected organ in IgG4 related diseases. In fact, majority of the cases are diagnosed because of this organ involvement, right? So what am I talking about? Yes, it is right. It is the pancreas. Pancreas is the most commonly affected organ. Pancreas involvement is seen in more than 80% of the patients who are diagnosed with the IgG4 related disease. Okay, then comes also a question, what is the most common manifestation of pancreas involvement, right? There is nothing more to say. The most common involvement of or the manifestation of pancreas involvement is development of the autoimmune pancreatitis type 1. So you can fairly call the type 1 autoimmune pancreatitis as IgG4 related pancreatitis. Okay, so this is about the organ involvement. Now apart from this, right, when you look into the organs, because these are all named diseases which I wanted you to know, but when you look into the organs of any disease or any of these patients diagnosed with either Ormond disease or Mikulicz or autoimmune pancreatitis, there may be evidence of other organ involvement. Now what organ manifestations we can see? Let me list from the top to bottom. So when you look at the pituitary gland, I have told you patients can develop what is called as IgG4 related hypophysitis, right? Very often these patients might present with the clinical picture resembling the pituitary adenoma. Especially the radiologist might confuse it as a tumor compressing the pituitary sac. Most common clinical presentation of IgG4 related hypophysitis is diabetes insipidus. That is the most common clinical presentation, because stalk compression or the posterior pituitary gland involvement is the most common site of involvement. Okay, now apart from that, in the lacrimal gland you can see swollen upper eyelids and dry eyes, and we will call this as IgG4 related dacroadenitis. Clear? Okay, now thyroid we are already familiar, Riedel's thyroiditis, or you can also fairly call it as IgG4 related thyroid disease. Okay, then salivary gland involvement, IgG4 related sialoadenitis, you can also call it as Mikulicz disease. Okay, now apart from that, respiratory tract involvement can happen, most of the patients of autoimmune pancreatitis might have complaints of chronic cough, and it might resemble clinically to bronchial asthma. Especially patients often have early morning worsening of the symptoms, so clinically you might think that this is the case of bronchial asthma. Okay, kidney involvement, together you can call it as IgG4 related kidney disease. The most important thing is patients might develop the tubulointerstitial nephritis, right? Patients might develop tubulointerstitial nephritis. Okay, then IgG4 related lung disease is an entity where again the chronic cough may be a presenting complaint. Now, biliary tract involvement is becoming increasingly common because we are aware of the biliary tract involvement in IgG4 related diseases, and the usual presentation is a form of sclerosing cholangitis. So that is why for a primary sclerosing cholangitis, this is an important differential diagnosis, right? We call it as IgG4 related sclerosing cholangitis. It is an extremely important differential diagnosis for primary sclerosing cholangitis. Okay. Then when it comes to the retroperitoneal cavity, we can call it as IgG4 related retroperitoneal fibrosis, or in the past we used to call it as Ormond's disease. Okay. Then there can be prostatitis because of the prostate gland involvement, and there can be lymph node involvement called as IgG4 related lymphadenopathy. It could be diffuse or focal. Okay, it could be diffuse or focal. And coming to the last and in fact the most important organ, that is pancreas. More than 80% of the patients would come to light because of the development of obstructive jaundice, right? Obstructive jaundice is the most common presenting complaint, usually painless obstructive jaundice, sometimes confusing the case to be a case of malignancy because of the tumefactive involvement of the pancreas. Okay, clear? So now what we know, what are the common shared characteristics of all these disorders? We know the organ manifestations, and we know the erstwhile diseases which are now coming under the umbrella of IgG4 related diseases. Clear? Okay, so now let us talk about the diagnosis. Now when it comes to diagnosis, there are two criteria. One is HISOT criteria, which you are very much familiar. I have discussed that in the autoimmune pancreatitis, which is mainly meant for diagnosis of the autoimmune pancreatitis. But if you make autoimmune pancreatitis as a diagnosis, you are already making the diagnosis of IgG4 related disease, because more than 80% of the patients, there will be pancreas involvement, and in fact that is the most common presentation, right? So can I say a HISOT criteria can be used for the diagnosis of IgG4 related disease? Pretty much fair enough, right? But also there's a diagnostic criteria proposed by Japanese Comprehensive Clinical Diagnostic Criteria for IgG4 related diseases. So let us look into it. What are they saying? So they say that you can diagnose a case as having IgG4 related disease if there are some three characteristics they have mentioned, if they are met, and they also give us the confidence level for diagnosis. So let us look into it. Point number one is clinical examination showing characteristic diffuse or localized swelling or mass in a single or multiple organ, right? So what we understood so far, it's a multi-organ involvement, but at the time of presentation, the evidence may be only of a single organ involvement. Fair enough. Like the organ that is affected might develop fibrosis or tumefactive lesion, right? Now, fibrosis can only be recognized by biopsy, but the tumefactive lesions might clinically come out easily, right? So if there's a swelling or a mass in the single or multiple organs, okay, that is the first point. Second, hematological examination shows elevated serum IgG4 concentration greater than 135 milligrams per deciliter. This is a second point. Okay. The third point is histopathological examination of the affected organ, showing marked lymphocyte and plasmacytic infiltration and fibrosis, right? That is what I said, fibrosing inflammation. Then the infiltration of IgG4 positive plasma cells. Now, the point to remember here is the objective information in the sentence, right? The ratio of IgG4 positive cells and IgG positive cells should be greater than 40%. That means in an affected organ, you've taken the biopsy and you're staining it for IgG per se and subvariant IgG4. Now, if among, let me say, 100 cells you found out to be positive for IgG, if out of those 40% or more than 40%, if they are positive for IgG4, right, that would validate this point. Okay. Plus the plasma cells per high power field under the microscopy, if they are more than 10, the IgG4 positive plasma cells per high power field of view, if they are more than 10, that is also a valid point. Okay. So we have discussed about 3 points. Now let us see how confidently we can diagnose a case as IgG4 related disease. Now, if all the three are positive, right? All the 3 points are there in a given case. So you had a patient presenting with a mass-like lesion of an affected organ. His IgG4 levels were elevated more than 135 milligrams per deciliter, and histopathological examination, right, shows lymphoplasmacytic infiltration fibrosis or the infiltration of IgG4 positive plasma cells with a ratio of IgG4 positive cells and the IgG positive cells is more than 40%. And if you are looking at the gross microscopic appearance, then more than 10 IgG4 positive cells per high power field, you can make a definite diagnosis of IgG4 related disease. Okay. On the other hand, you can make a probable diagnosis of IgG4 related disease if 1 and 3 are positive. 1 and 3 are positive. See, I'll tell you one important thing. In fact, this is a statement which appeared in one of the exams. Whether elevated serum IgG4 levels is specific for the diagnosis of IgG4 related disease, the answer is no. Among the 3 points mentioned in this diagnostic criteria, the least utility is with this point number 2, because in various other conditions, including several of autoimmune disorders, the serum IgG4 levels may be more than 135 milligrams per deciliter. Right? Clear? Okay. So now, if a patient presented with a tumefactive lesion and he's histopathologically, he's sharing these characteristic features that we discussed, right? Then you can make a case as probable IgG4 related disease. Okay, so 1 and 3 positive. Now, if 1 and 2 are there, that means patient has clinical features suggestive of a tumefactive lesion in an affected organ, one or more organs, and his serum IgG4 levels are elevated, but either you have not done the histopathological examination or histopathological examination is not consistent with the findings that I just described, then you would call them as possible case of IgG4 related disease. Right? Clear? All 3 definite, 1 plus 3, that is the clinical examination showing a tumefactive lesion plus the histopathological features, then it is probable. Then 1 plus 2 means you don't have a histopathological evidence, but you have elevated IgG4 levels and a tumefactive lesion, that kind of a clinical presentation. You can say possibly a case of IgG4 related disease. This is according to the Japanese Comprehensive Clinical Diagnostic Criteria. But you should also be aware that if you diagnose any case as autoimmune pancreatitis type 1 based on his sort criteria, you're already making the diagnosis of IgG4 related diseases. So if there is a question mentioning his sort criteria for diagnosis of IgG4 related disease, it's still a valid point. Clear? Okay. Now coming to the management. The good thing about all these IgG4 related diseases, excellent response to steroids. Right? So that makes steroids or oral corticosteroids as the drug of choice for management of any of the spectrum of diseases of the IgG4 related diseases. Okay. Now, when I start steroids, what do I expect? The use of steroids will reduce the number of IgG4 positive cells, normalization of histopathology, right? Arrest of the progression of the fibrosis, and reduction in the bulk of the affected organs, because those cells were infiltrating, increasing the bulk, cells decrease, the bulk decreases, right? So autoimmune pancreatitis, what was the drug of choice? Oral corticosteroid, right? Any other IgG4 related disease, the drug of choice is oral corticosteroids, and obviously that would be the first line. Now some patients may not show good response, or there may be relapse after steroid withdrawal. That's the real problem here. Steroids show beautiful response. Anytime you start steroids, right, tumor size or the tumefactive lesion size shrinks, histopathological changes start reverting to normalcy, and organ function starts improving. But at least in 1/3 of the patients, withdrawal of steroids might lead to reappearance of the symptoms. So for such patients, either you have to think of maintenance steroid therapy or the immunosuppressants, right? So immunosuppressants can be considered as second line agents. Immunosuppressants are the second line agents. Okay, now what do we use as second line agents in immunosuppressants? Well, you have plenty of options, right? You can think of azathioprine, you can think of mycophenolate mofetil, right? You can also think of tacrolimus or other calcineurin inhibitors. These can be considered as the second line agents in those patients where either primary failure is there, steroids are not going to show clinical and histopathological improvement, or there is a relapse after the steroid withdrawal. Again, you need to weigh the risks and benefits of steroids as a maintenance therapy versus immunosuppressants, right? If you're using immunosuppressants, main thing is you're mostly using because of the steroid sparing nature, because otherwise the steroid primary failure is rare, and like those patients where steroid withdrawal had resulted in the reappearance of clinical features and the tumor active lesions would mostly respond again when you give them a full-fledged course of steroids. But repeated exposure to steroids or a long-term maintenance of steroids would bring their own set of side effects. That is why, as an alternative thing, you can think of using the immunosuppressants, right? Okay, so that's it on this video module, guys. I'll see you in the next video module. Let us talk about one more interesting topic. Till then, have a good time.